So for the purpose of this video, we're just trying to talk about how to intubate a COVID patient. I would be wearing a PAPR and full PPE, but for the purpose of the video, I'm not going to do that. So the patient arrives on nasal cannula. We're going to make a decision that they need to be intubated, and so we're going to pre-oxygenate them with a non-aerosolizing setup. So Joe is going to put the non-invasive mask on, and as they're doing that, so this is a non-invasive mask with a blue elbow with a viral filter attaching into a BVM with a PEEP on it, secured down tight prior to any oxygen being put into it, because once you oxygenate, if you have a leak, then you've aerosolized. We'll put the patient on flush rate O2 at 30 plus liters a minute. And at this point, we want them in this setup for about 3 minutes. We want to minimize everything in the room that could get contaminated, so we have prearranged to have our intubation equipment ready. So our ventilator will be immediately put on post tube insertion. We have an inline meter dose inhaler adapter on it in case they need albuterol. We have an inline suction catheter already loaded on it for suctioning. We have an inline end-tidal CO2, which will be our primary confirmation of tube placement immediately following the delivery of the tube. We have a rescue eye gel in the room. We have a bougie in the room. We have our glide scope in the room with a bag over the top to protect it. And for ideal cases, you just have 2 blades at your disposal so you don't contaminate other products. We will preload the patient while this is going on with their tube holders, so we have less to do following intubation. One of the lessons that we've learned in practicing this is we simulated a failed tube that I couldn't deliver, and then I removed it. Anything that comes out of the mouth should be gauze wiped slowly as it comes down, so we have a stack of gauze at the ready for that. With anxiety of missing a tube delivery, we tend to be a bit cavalier with bougies and tubes, so to be mindful of that and to have trash bins already set aside so you can deposit things off to the side quickly so that they don't contaminate the space any more than it's already contaminated. The nurses are kept to a minimum in the room. There'll be the respiratory therapist, the primary intubator, the primary nurse, and then a recording nurse who will be outside the room with a radio in communication with the primary nurse, and that radio will be underneath his or her gown so that they can depress that, and that will be pre-tested. We will have a talk through of everything we do prior to intubation and what happens if it fails. We'll have drugs in the room for post-intubation sedation, and that will be thought through. We'll have an orogastric tube in the room, a Foley in the room, and try to minimize going in and out by having everything you need, and we're creating a list that'll be posted for those who are interested in that. So I'm going to just go ahead and simulate an intubation at this point to talk about the most important part of this, which is empowering everybody in the room to remind us to turn the oxygen off before the mask is removed. So if we fail to do that, we will have aerosolized with 30 liters flush rate into the room all those viral particles. So the patient's been pre-oxygenated. We've delivered 200 of ketamine and 200 of sucks. Fasciculations are now seen, and so now we're going to proceed with intubation. I'm going to turn off the oxygen. You're going to remove the mask. I have suction ready, which I've already tested. We'll suction. Try to make safe placement of your suction. Ideally, we're using video laryngoscope because it keeps the intubator's head further away from the patient. We're again being careful about this. I'm going to drop this into my trash, which is to my side. We're not turning the oxygen on yet. And the oxygen is then hooked up to her vent setup, and she will engage the oxygen at that point. We would have somebody securing this tube, and we'd be working as a team to do that. So we've inflated our cuff, we've secured our tube. We're using end-tidal CO2 waveform capnography as our primary for tube confirmation, which then eliminates the step of having to lean down close to the patient with your head to listen to breath sounds.